Can anyone hear me?
Yes, we can hear you.
Yes, we can hear you.
Okay. Nick, we have 65 people on. Do we want to start?
Yeah, I think we can go ahead and get started, Apollo.
Okay. Good evening, good afternoon, good morning, everyone. And for those who are even listening to us from the far away in the Asian area, we greet you and we appreciate the time you are taking to join this webinar. The webinar is part of the series of the Elizabeth Glaser Pediatric AIDS Foundation, the series of evidence. And this month we will be discussing the multi-month ART. What do patient care and outcomes look like within the first year? And we are going to summarize results of studies in Cote d'Ivoire, Mozambique, and Eswatini. So before I start with my opening remarks, I will hand over to Nick to give us some of the housekeeping.
Hi, everybody. Good morning, good afternoon, good evening. Thank you so much for joining us on this next installment of the Evidence to Action webinar. Before we get started, we just wanted to share that interpretation is available in French and Portuguese. If you would like to switch to the French and Portuguese channel, you can click the interpretation feature, which is a globe icon on your screen, and then choose which language you would like to hear. If you only want to hear the French or Portuguese language and not English, you can click mute original audio. You can also introduce yourself using the chat feature, and please feel free to submit your questions and comments using the Q&A feature. And a note for everybody on our webinar today, it is being live streamed and it is being recorded, and we will share a recording at the conclusion of the webinar across our social media channels and EGPAF Impact newsletter.
But thank you very much, Nick. Our webinar, this is the agenda of our webinar, and I can just go straight to, our panelists. They will introduce themselves as they talk. When it is time for them to talk, and we will run through the presentations. And at the end, during the presentation, just go ahead, like Nick said, and put in your questions. And there will be time at the end for discussion, during which we can open the line for you to speak. As opening remark, I will take note that differentiated service delivery models of care has revolutionized the approach in providing HIV services to our clients across several countries, especially in the context of test and treat. Of importance is the multi-month dispensing of medicine that came handy, very handy, during the recent pandemic in ensuring continuity of care for patients. However, we know that in all these strategies, to optimize care for patients, children, are usually left behind.
Okay, well, we may have lost Apollo for a few moments, but can you all hear me now?
Yes, we can hear you.
Great, thank you. All right, so I think as Apollo was noting, multi-month dispensing has become, I think has increased in attention and importance to a lot of our programs, and we wanted to share some findings from several evaluations that we've conducted in these 3 countries. So with that, I'll hand it over to Marc N'Goran, who is the director of the INILI Project with our Cote d'Ivoire program.
Good morning, good afternoon, and to everyone. I'm Marc N'Goran, Program Director for Project INILI in Cote d'Ivoire. I will be presenting a few slides. So multi-month dispensing of MMD refers to the practice of dispensing at least 3 months of ART at pickup visits rather than just 1 month, which had been the standard practice for many years. With an emphasis of new clinical stable clients initiating on lifelong ART through the test and treat approach, health facilities began to offer multi-month dispensing to ease the burden on both client and care providers. Initially, most facilities only offered multi-month dispensing to clinically stable adult patients. But the COVID-19 pandemic had a significant impact both on accelerating the uptake of multi-month dispensing, which you can see from this graph, showing the proportion of both adult and pediatric clients on MMD modeled in 21 countries, and on making the MMD model accessible to more clients, particularly to children, pregnant women, and patients who did not meet clinically stability criteria. Next. In Cote d'Ivoire, we conducted a study entitled Evaluation of Viral Suppression in the Context of Differentiated Care in Cote d'Ivoire. The study had 2 components. Firstly, we reviewed client charts to understand how many clients were eligible for MMD and which clients had already been transitioned to MMD. And secondly, we followed up a cohort of clients newly transitioned into MMD for 18 to 14 months to better understand the outcome, like viral coverage, viral suppression, and also to see whether they continue to receive MMD or not. 29 sites were selected across the country for the study, and people living with HIV on ART aged 1 year or more were newly transitioning to MMD where the study population. Participant enrollment was done between March 2020 and January 2021, and data collection lasted from March 2020 to August 2022. Next. We reviewed medical record for more than 41,000 clients, and 90% of them already received MMD. In March, as I said, in March 2022, due to COVID-19 pandemic, the guideline was a bit changed to authorize the client to enter a MMD model. And the client first receiving MMD during the COVID-19 has some specificity. They were younger, they initiated ART more recently, and they were less likely to have had a viral load test and more likely to have been unsuppressed at the last viral load test. And they were also more likely to have a history of opportunistic infection. Next. 52 adolescents and children less than 18 years participated to this study, with 70% of them being under 10 years. The majority of these adolescents and children were male. 35% of them had at least one deceased parent, and 40% had been on ART at least 2 years at first receipt of MMD. Next. For adults, the median age was 41 years, with female representing 70% of them. 34% of adult participants reported over household members on ART. We also notified that 23% of adult participants had been on ART at least 2 years at first receipt of the MMD. The particularity here is that 36% had been on ART less than 6 months of the first MMD, and this is due to COVID-19 mitigation measures. Next. So in order to see the fidelity in MMD, we assess the consistency in receiving MMD. And as you can see here in this slide, among the 711 clients enrolled in the study, 92% of them had 3 or more ART pickups. And MMD was consistent for 70% of them. The rate, of course, was lower among the children, where we can see that also we can see it's less among the children. Next. So here we can see that, this is, we have less among the children, where 38% are consistently on MMD. Next slide. So we do have some reason for discontinuation of MMD. And for adults, we can see that provider decision was one of the key reasons. And also participants having a high viral load was a reason for discontinuing MMD. These are the most common, but we can also see that other reasons are following, especially stock out of ARVs, pregnancy among the women clients. We also notified some concern about adherence and the need for the client to return for sooner viral load monitoring. The reasons are quite the same for the children. Next. Here we can see that the viral coverage among study participants after at least 12 months follow-up is 95%. This is for adults, and this result is quite similar to what we see in the program. And for children and adolescents, the viral coverage is 98%, which is, let's say, better than what we see in the program. Next. As a result for the viral load, among the 659 adults of the cohort, 91% got at least one VL test 6 months after first receiving MMD, and 88% of them had viral load, continuous viral load suppression. 12% of them did have at least one viral load that was not suppressed. And the result for the children is a bit different, where we can see that 28% had at least one viral load that is not suppressed. So let me pause here and hand over to Lauren for the other part of the presentation. Over to you, Lauren.
Thank you, Mark. We can go to the next slide, and I'll be sharing some results from two different but similar evaluations of MMD among children under age 15 in both Mozambique and Eswatini. So both of these evaluations relied solely on existing data collected through routine care, and that was at 16 facilities in Mozambique and 31 facilities in Eswatini. And in both cases, we collected data like ART pickups, clinical visits, and viral load results from approximately 2019 through either late 2021 or early 2022. Next slide. The objectives were similar for both evaluations. We looked at how many children ever received a multi-month supply of ART. And again, that's defined here as a receipt of at least 3 months of ART at a single pickup. We looked at when they first received a multi-month supply and whether children who ever received MMD differed from children who never received MMD. We looked at how many children continued to receive consistent MMD. And again, we defined that as receipt of a multi-month supply at every ART pickup within those first 12 months after their first receipt of a multi-month supply. And then finally, we looked at viral load outcomes, both coverage and suppression, among children who ever received MMD. Next slide. So here you'll see the age distribution of clients included in our analysis. So you'll see that the distribution in Mozambique is fairly even across the 3 age groups, whereas in Eswatini, we had more than half of the clients were between the ages of 10 and 14. 20% of the children included in analysis in Mozambique were fairly new to ART, having initiated within the last 6 months, while this number was much lower in Eswatini at only 5%. In total, we found that 82% of children in Mozambique and 67% of children in Eswatini had ever received a multi-month supply of ART during the study period. Next slide. So we looked at which children received MMD and which children didn't. And as I think we probably expected, this was highly correlated with age. It was much higher among the oldest children, and it was lowest among the youngest children. In Mozambique, we also saw that the receipt of MMD was correlated with time on ART and time in follow-up. So children who transferred out or were lost to follow-up were less likely to have received MMD prior to that. Also, children with a record of having an opportunistic infection, malnutrition, or an unsuppressed viral load were also less likely to receive MMD during the study period. In Eswatini, we saw a lot of variation by site, with some sites having a very high proportion of children on MMD and other sites with very few children receiving MMD. And we also found that of the 2 regions where we conducted the evaluation, one region had a significantly higher proportion of children on MMD. Next slide. So similar to what we saw earlier at the global level, in both countries here, we really see that dramatic rise in the number of children starting MMD in the early months of the COVID-19 pandemic. And then it tapers off. And there's a small increase again in Mozambique around January of 2021, and that does coincide with another spike in the number of COVID cases in the country at that time. Next slide. And similar to what we did in Cote d'Ivoire, one of our objectives was really to look at whether children who started to receive a multi-month supply actually continued to receive multi-month supplies. We looked at a 12-month period starting with that first receipt of a multi-month supply, and we calculated the number of children who received a multi-month supply at every ART pickup in that year. Again, similar to what we saw with Cote d'Ivoire with the children and adolescents, we found that only 40% of children in Mozambique and 31% of children in Eswatini received a multi-month supply every time. It was highly correlated with age, but we also saw that children who had a regimen switch, which was common during this time, were less likely to receive consistent multi-month supplies, as were children with adherence concerns or children who had had an elevated viral load. Next slide. And then finally, we looked at viral load coverage and suppression among these children who ever received a multi-month supply. So 40% of these children in Mozambique had a viral load within 12 months, And we did actually find that children who received consistent multi-month supplies were less likely to have had a viral load. And looking at the viral load results, at least 6 months after beginning MMD, we found that 79% of children were suppressed, and it was really the youngest children who were less likely to be suppressed. In Eswatini, 87% of children had a viral load within the 12 months after they first received multi-month supply, and there was no significant association with either age or consistent receipt of MMD. 93% of children in the Eswatini analysis were virally suppressed, though again, this was lowest among the youngest children. So next slide. So that concludes the selected results that we wanted to share today. As you can imagine, we collected a lot more data. There's much more that we hope to be sharing through different means, and we'll communicate those with everyone. But we wanted to give you a little overview of some of the things that we found. We want to acknowledge all of the teams who supported this work, both within EGPAF, at the ministries, our funders, and various other partners and investigators. So we won't go through, I won't name everyone, but we appreciate the support from everyone listed here, as well as others. And so what we want to do now is to give some room to some of our technical staff, our program staff from these 3 countries, to comment on what they think are the most salient points from the research and what they think are some of the implications or some of the work that they're already doing to respond. So with that, I'd like to maybe start with Marc, if you could maybe comment first, and then we'll ask Lydia from Eswatini and then Bonou from Mozambique to share some of your thoughts. Thank you.
Okay, thank you, Lauren. Yeah, I think this study was a study of great interest at national level, including the MOH used to take the leads in some of the results and how to turn them into concrete action. So the first thing is that it was a real life study implementation. So the result were somehow used to improve, program implementation through regular feedback to care providers. So that helped to improve, for example, the documentation, the patient follow-up system, the VL offering, and also the management of patient schedule. This is one thing. Also, we noticed that, as I shared in the study, that we do have some issue with continuity in receiving MMD due to drug stock out. So the result has been used to help the management of the supply chain so that we can, in the best way, avoid drug stock out. So these are some of the things that I would like to share, and in terms of how the findings of the study was used in the concrete program implementation area. Yeah, over to you.
Thank you, Marc. Lydia, would you like to comment next?
Okay, so good afternoon and good morning to everyone. I think that the previous speaker has really highlighted some of the really salient features, and I think that this is true across the different countries from the evaluation. As Eswatini, the benefits of multi-month dispensing have been really embraced, but as we have seen from the study, children still lag slightly behind for several reasons. As was mentioned before, this was done during the transition to pediatric DTG and to DTG, and so this really speaks to how we support our facilities when there is a transition. I think that, as was highlighted before, the issue of viral load scheduling is something that we need to think about even as we are doing MMD. In Eswatini, we did have a big struggle with viral load coverage, especially for our children. And so one thing that we have seen is shortened refills for other appointments. And this had also contributed towards some of the results that we see. So I think in terms of programming service integration into DSD models, and also integrating differentiated dispensing across DSD models is some of the take-home messages that we have for the Eswatini program. We did find that most of our children were older, as was highlighted by the presentation, and most of them actually had received MMD. But because of some of these reasons, we did see a bit of a decline in MMD. I think as a program, also the issue around data quality is something that really spoke out. We did see differences between our electronic data and the abstracted data, and this also has been a take-home message. But on a very positive note, we're happy to see that in terms of our viral load coverage and our viral load suppression, it did coincide very, very nicely with what we're seeing in terms of programming. Yeah, so I think that probably that is what I will share. Thank you.
Thank you, Lydia. And Bonou, will you share some of your observations from the Mozambique program?
Thank you very much, Lauren. Good morning and good afternoon, everyone. What I can add to what has been said already is that the guidance from 2020 to 2017 from WHO has helped to remove institutional barrier that was related to the inclusion of children of multi-month dispensing, and this has helped Mozambique to put in place those this guideline to allow the inclusion. So we can, that's why we can see that most of the children has been included during the period of implementation of the study. That is also the peak that has been reached during also the peak of the COVID pandemic. The finding has helped us to identify the barriers that we are facing implementing the pediatric care, especially on how to improve the retention and also the viral load suppression. We have identified that we need to improve and to introduce some improvement intervention targeting providers, especially to improve the content of the psychosocial support, because there are a lot of missing opportunities for those children that meet eligibility criteria but are not put on multi-month dispensing. We can also see that by improving the psychosocial package on targeting the caregivers, it can help them to understand the reason why they have to bring to each consultation, especially those we need to collect sample for viral load. It will help to improve the viral load coverage and also to be monitoring the viral load suppression. So this is what I can say from the finding that we saw from Mozambique study. Thank you.
Thank you. And Marie-Huguette, would you like to share anything else from the Cote d'Ivoire program?
Thank you, Lauren. Hi, everyone. What I can say, I think Marc said most of the things that has been relevant from Cote d'Ivoire, but I just had something about the great interest that we have from this study at the national level, including the Ministry of Health. And I think we also have a dissemination meeting with all the key stakeholders involved in the HIV activity in Cote d'Ivoire. And it was a great meeting, and we share all the finding that we have with this study. So it was a great interest for this study, the MMD study in Cote d'Ivoire. Thank you.
And then Apollo, if you're back online, would you like to share any final thoughts?
And thank you very much, Lauren, and thank you, everyone. And before we go into the questions that are coming in the chat Q&A chat, I think it's important that the data here, we look at it from the perspective of these programs actually started children on MMD. I think that is the key thing. And you know, the appeal here, or the advocacy here, is that all of us on this call, if we can really continue to expand the enrollment of children on MMD and tracking and monitor them accordingly, you know, and adapt the MMD strategy on the needs of the children in the context of patient-centered care, I think we will have a great result for the children, because it's challenging to think that moms come once every 6 months or every 3 months to pick their medicine, but have to bring their children to the facility, you know, every month. At the end of the day, putting mom on MMD, you know, will be more efficient if the mother-baby pair are both put on MMD. So that being said, I would say maybe the panelists, we can move to the some of the questions that are in the chat room. And thank you, Lauren, for beginning to answer Shabir's question, and Rebecca, some of the answers have been provided to your question, and Lydia will continue to, you know, type some of the response as I take note. So if there's anybody who wants to ask question, you know, by unmuting self, maybe we'll open the, you send a chat to the panelists, and then they will open the line for you to ask the question. Lauren?
Sure. So I wanted to address, I think if you can open up the Q&A box, which I think everyone has access to, you'll see a few questions that have been answered. Shabir had asked about looking at differences in viral suppression among those on MMD versus conventional pickup. That's something that we're still looking into a little bit. I think one of the challenges here is that we know that the population is different. So if the goal is really to try to look at the effect of dispensing on suppression, you would want to take those differences in the populations into account. And so that's something we're still looking into, but we agree is a relevant point. That is also something that I think we have more data on from controlled trials, particularly for adults, but there is much less data on children. Rebecca had asked about viral suppression among the younger children. Apollo had responded to that. I'd also welcome, you know, our other panelists to weigh in on that in a moment. I believe both Lydia and Bonou are responding to Rebecca's question about eligibility criteria for MMD. We also saw during the COVID-19 pandemic that eligibility criteria really opened up. Younger children, often down to age 2, I believe actually down to age 1 in Cote d'Ivoire, if I'm not mistaken, were eligible. And there were also, there was some easing of the requirements when it came to clinical stability. I also saw a question about 3 versus 6 month MMD. We did collect that data. We didn't present it here, but we certainly can share that. In Cote d'Ivoire, we saw very little 6-month MMD among the children. We did see increasing 6-month MMD among the adults. You know, there was very little at the beginning, but again, these were people who had newly initiated MMD. So we would expect that really they would have started on that 3-month model, but then a number of them over time. So I think, you know, quite a few of them by the, you know, 18th, 24-month study visit had been moved to that 6-month dispensing. We did also look at that in Eswatini. Again, relatively few children on 6-month dispensing, but there were some. In Mozambique, 6-month dispensing really hadn't been a practice for children. 6-month and even 12-month dispensing has been piloted for adults. And EGPAF actually has an evaluation plan to look at those longer periods of dispensing in adults, particularly for migrant populations. So we hope to be implementing that and sharing those results within the year. And then, so I think that covers a lot of some of the message questions. So I would open up to the other panelists if you all would like to comment. Marc, please go ahead.
Thank you.
Okay.
Thank you, Lauren. Marc.
Okay, thank you very much. Yeah, I think in addition to what Lauren said, we used to separate and do the analysis for 6 months and 3 months provision. In Cote d'Ivoire, particularly, we did not present the data, but there is a great number of participants who have 6 months of MMD. We have some outliers of people having 9 months MMDs, but the more than 7% of them were on 6 month MMD, and the over 30% on 3 month MMD. In terms of outcome, the outcome were a bit similar for both categories, so no major difference. What I can say in terms of major challenge for Cote d'Ivoire, and I think it's the same in the other countries, is the supply chain challenge. As you know, provision of MMD demand a strong supply chain management, availability of ARVs, so that what is prescribed is what is dispensed. And we used to find this different. Sometimes they can prescribe 6 months, but because of drug issue, we can just provide 3 months or even less than 3 months ARV. So this is what I wanted to add to what Lauren already said. Over to you.
And I think Bonou and Lydia also would like to comment on this. So I know Bonou, you noted in the chat that you wanted to respond. So Bonou, why don't you go ahead and respond? And then Lydia, if you would add your response after Bonou.
Okay, thank you. No, what I wanted to say is the challenges are quite the same supply chain, because when children is started on a treatment and then at the next visit those drugs are not available anymore, it's become challenging to continue providing the same regime. So this need to be interrupted and then to give another regime that more or less will respond to the status of the children. So supply chain was one of the challenges. And I was responding also to one of the questions on eligibility criteria that is quite aligned with WHO regime. The children has to be more than 2 years old and on ART for more than 3 months, and with not on TTB treatment and not suspected on treatment or on treatment failure, and also not with any health situation of WHO or stage 3 or 4. So those are the eligibility criteria for MMD in Mozambique. Over.
Thank you. And Lydia, if you want to respond to that. And then also, Lydia, there is a question about scheduling for viral load monitoring in relation to MMD. And I know that you have, that you've thought about this a lot. So maybe if you could also speak to that a little bit.
Yes, so thank you very much. So the criteria for MMD in Eswatini is the same as in Mozambique, except for us, we also need the child to have a suppressed viral load. Our viral load suppression, especially for the younger children, has been quite low. and that could be been a contributing factor to the low uptake of MMD, but this has really greatly improved. But what I would like to say is something that I'm not sure whether it was Marc who spoke about it, was the issue of psychosocial support, because that is one of the things that we have seen from mentorship and working with healthcare workers has been one of the contributing factors, because children who have got poor adherence or who develop a detectable viral load will need a shorter interval to the next visit. We also have got majority of our children in DST models like teen clubs, which tend to meet at a shorter interval. And really, I think that the take-home message for us is aligning DST models alongside the recommended refill, and also collaborating with our community partners in order to close that gap in terms of adherence support. Now, in response to the question about viral load scheduling, yes. So I think that this, I've spoken to this, that yes, we did have shorter intervals to the next visit because of viral load scheduling if a patient was unsuppressed. And we did active cohort tracking in order to make sure that these patients came back to care. I don't think that the analysis for this one, for patients failing treatment, was accounted for in the MMD coverage. Thank you.
Yes, Marc, would you like to add something? I see your hand up.
Yeah, just to add to the question related to the adherence among children and adolescents compared to those who were not on MMD. I think this was not clearly, assessed, but at program level, you can see that it is a challenge because children and adolescents demand a very active follow-up to ensure that they adhere to the treatment and that they continue taking the treatment to remain viral suppressed. And so in the study, we anytime the children come to the pickup, the care provider will check the adherence. And if it is the situation that the children is not adherent, it is one of the reasons that we can interrupt MMD. So yeah, we did not collect data and compare to those who are not on MMD, but it was closely monitored to avoid, viral replication, viral load replication. To the other side, we did not check to see whether the client are KPs or children of KP parents. This was not part of the study, but I think it is a good thing that we can think about for next other studies. Thank you. Over to you, Lauren.
Thank you. One other thing I would note about Nimasha's question about adherence, I think we know that children where there is documented concerns about adherence were often less likely to start receiving multi-month supplies in the first place. So I think the comparison's a little bit challenging. I think that it's helpful to note in Mozambique, we did look at adherence to ART pickups among children who had ever received a multi-month supply. And we found that there was a positive association between receiving consistent multi-month dispensing and completing the expected number of ART pickups within a year. The causality of that is a little bit difficult to determine, whether, children who were receiving multi-month supplies, that somehow promoted adherence to ART pickups, or whether it was that children where adherence was a concern were then more likely to be transitioned back to more of a monthly dispensing model. Those are some things that we're still attempting to tease out a little bit. I think adherence also, there's multiple ways to look at that, whether you're looking at pill counts and adherence to, you know, daily medication. We do have some data on that. But mostly I think what we've looked at so far was really just adherence to ART pickups. And let's see. I think we've answered some of these other open questions about some of the viral load monitoring, some of the challenges with the supply chain, during the follow-ups to know if they. So the question of adherence. Oh, go ahead.
No, I wanted to take Tulani's question. You know, because his question is whether any of the country had looked at the impact of viral load suppression before after introduction of MMD, and if it also had different effect on adherence. Tricky question, you know, which were not part of the objective of the studies that are being presented here. However, I think the same group, the EGPAF group, in collaboration with Radcare, ran a study in Lesotho, the non-inferiority study around the MMD, you know, where we look at the viral load suppression for patients who were on MMD. And at that time, the criteria to be on MMD were the patient needed to be virally suppressed. Certainly at the end of the study, you know, the MMD, you know, was non-inferior to those who were coming to facility to get their drugs, you know, and I think that gave confidence to the Ministry of Health to continue to expand the MMD as a strategy in Lesotho, and the data have been published. I can share some of the publications with you outside of line. Thank you. Over to you, Lauren.
Well, I wanted to address the question about how did you do the follow-ups to know if there was good adherence to the ART medication? And so I think, you know, if I could ask some of our panelists to maybe speak to what are some of the practices that providers are using or are trained to use to help assess whether a child or an adult should continue to receive month-by-month supply, or whether they should be transitioned back to more of a monthly model, and specifically how that relates to adherence. So maybe Lydia, you can start, and then Marc, you can weigh in.
Okay, so thank you very much. In Eswatini, we do different ways of tracking adherence. We look at keeping of appointments, and we do have a system that flags immediate patients who have immediately missed an appointment, and we follow them up. We also do an assessment of adherence using pill counts, and then we also use viral loads in order to assess how a patient is taking their medication. So those are the parameters that we are using, that we sensitize our healthcare workers to use. Now, during COVID, the issue around viral loads was relaxed. And so it was really more about keeping of appointments and the pill counts. And also that expanded to other DSD models, because we went into the community and we were doing community drug distribution, where children were also eligible to access drugs during this way. Thank you.
Yeah.
Right, Marc?
Yeah, I think the practice are quite similar to what is done in Eswatini, or just how that for the sake of MMD, we here in CDI, we establish both system of follow-up in the community, right in the community for children. We have community counselors that are actively follow up the children with community to ensure that they adhere to the treatment by pills count, and also management of the rendezvous. So this was something that was done in the community for children, but also for adults to ensure that when they have 6-month medication, they really take the medication in the community. We have also this community follow-up component that is going to the house of the patient and ensure with him by pills count or by questionings to see whether we continue to take the pills according to what is done. And in addition to that, during the study implementation, we started the home distribution of ARVs due to COVID mitigation plan. So this was also one of the things that we added to this program. When they go to the home, they take the opportunity to verify, to count the pills, to see also the characteristics of the patient, and we can identify whether he's observing or not. Over.
Laura, if I may add?
Yes, please.
Yeah, in Mozambique, let's say before COVID, the eligibility criteria to enter into a multi-month dispensing was to complete at least 6 months of ART and having viral load suppressed. But with COVID, the viral load suppression condition has been removed, and also the duration on ART has been reviewed to 3 months. But the tricky situation in Mozambique is if a patient is put on multi-month dispensing, and after having a viral load is found with viral load not suppressed, then this patient loses eligibility to be part of multi-month dispensing. So this is a tricky issue that we are discussing in technical working group at national level, and we hope that this will be changed, because the patients are put on multi-month dispensing to improve their adherence, actually, and by failing to the appointment, which help to measure the adherence, or to find out that the viral load is unsuppressed. Removing them from multi-month dispensing is like we are not helping them anymore, and it's quite contradictory. So, but what I've experienced from any other countries, I know that this is not the right way, and we are trying to convince the Ministry of Health not to do so. There is also an international advocacy on that to change this policy, and we will see how to respond to that locally. Over.
Thank you. Yes, Marc, did you want to make I think we're getting to the end, but maybe if you want to make a closing comment? Yeah,
just say that, yes, multi-month dispensing is a good thing, but it's a good thing when we have a clear follow-up system in place to ensure that the patients who are receiving multi-month dispensing are continuously taking the ARVs according to the rules. In Cote d'Ivoire, we used to show that some of them enter the MMD with a viral load suppressed, and then 12 months later, or even 18 months later, they became, they had unsuppressed viral load. So this is an issue, and we think we need to have a good focus on that one to ensure that patients have good, they are healthy and continue to take the ARVs. This is what I wanted to say, and yeah, thank you. Over to you, please.
Thank you. And Lydia, did you want to make one last comment before we wrap up?
Yes, just to echo what my colleagues have said, that MMD is really meant for the benefit of the children, and we have seen the benefit, especially in unstable children. But we need to look at integration of services to ensure that we do not have to shorten appointments or have patients come more frequently to the facility. And also we need to be able to support adherence and psychosocial support, because this, from the discussions we've had today, appears to be quite a contributor, though it's something that still we will need to evaluate. Thank you.
Thank you so much. And I think we'd like to thank all of our panelists today. Thank you for joining us, especially on a Monday. Apollo, would you like to make any closing statements? And then Nick, I'll ask you to remind us where people will be able to find this recording. And I'll also just note that we're still looking at some of this data. We are looking into presenting more of it. Clearly, we have a lot more that we collected that we'd love to share. So please, keep an eye out, and we'll be sharing more of this. So Apollo, over to you if you'd like to make a final comment.
Thank you very much, Lauren, for leading the conversation. And most importantly, appreciation goes to the panelists and, of course, our patients who participated in various studies. I think in this series, it's important that as participants, we remember children, we have to start. We cannot be too cautious to the point that we don't give children opportunity to be careful in the optimal way, or, as we establish patient-centered care. And I know there have been questions about the supply chain, and the issue around supply chain during the COVID was a general one. And I think as we continue to roll out, the MMD for children and adolescents, we will be learning more, and we'll come back and share with all of you. Thank you so much, and I'll see you and talk to you the next E2A. Over to you, Nick.
Thank you, Apollo. A reminder to everybody that the recording will be posted on EGPAF's YouTube page, as well as across our social media channels. It will also be posted to the resource library of EGPAF's website, and it can also be found in an upcoming edition of the EGPAF Impact newsletter.
And I'm just seeing that I think there may have been a few additional comments in the chat section that we couldn't see as easily as we could the ones in the Q&A. So please feel free to reach out to any of us from the EGPAF team for more information on any of these studies. We're happy to share or to discuss further. So thank you all for attending. We appreciate you spending your time with us.